Dr. Bhadre will talk on gonioscopy.
Yep. So just a moment. Let me get to full screen. Right. So as we have seen in most of our lives, gonioscopy is the most neglected test in the OPD. And unfortunately, the entire glaucoma management is fully dependent on gonioscopy because treatment protocols for POAG and PACG and secondary glaucomas are all different. So there cannot be one on another one. And India is an angle of country of angle closure, as Sukanya said earlier only. Unfortunately, this anterior chamber is visible, but angle of anterior chamber is not visible because on the slit lamp examination. So therefore, we need to incorporate gonioscopy so that it can be done easily and it can be a part of the comprehensive examination. But what is actually coming in the way? The biggest hurdle in all the mind is the mindset. People feel it's time consuming, it's cumbersome, and it's not really essential. Second thing is, such good drugs are available, surgeries are available. I'll prescribe drugs. Why do I do a gonioscopy and waste my time? Another thing is difficulty in the technique and the equipment. Many people haven't really learned the technique well during residency. And that is one of the reasons this comes away. As another thing is that in residency, when we teach the technique, we teach so many classifications that a student is so thoroughly confused about the classifications that when they move out, they feel it's something difficult, it's something challenging, complicated, so let's get done with it. But the mindset, the most important factor in the entire thing is a mindset. So the moment a person understands the value of gonioscopy, it becomes automatically incorporated. All the hurdles are this thing. The fear of failure of interpretation is another thing which really comes in the way of multiple people who are very uncomfortable about doing gonioscopy. So how it comes is that why should we do it? First and foremost, classify glaucomas. If there is angle closure, how much is it there? Will it occlude on dilatation, or will there be abnormal structures which are going to be troublesome in the end? We cannot see. And finally, will it progress? So in history, if we are not able to do it, everybody, let's see in history, if their patients are above 40 years of age, young adults with history of glaucoma, there's trauma, steroids use, family history of glaucoma, epiphora, if any of these things are there, children with large eyes, gonioscopy becomes mandatory. Then when we do a slit lamp examination, if angle appears narrow, actually all this Sukanya has already told, so I won't be wasting time on it. But if you see signs of acute angle closure glaucoma, or you see on the pupillary border pseudoexfoliation, neovascularization, and tears, is mandatory again. Then if there is a raised IOP in any of the secondary glaucomas, then coming to lenses that we use. The CAPES lens is only for the value of it. Now we use a 4 mirror under the slit lamp. It works perfectly well. So the mirror, the lens that we generally use is a 4 mirror. We can use 2 mirror also. 2 mirror actually needs the coupling medium. And then with 4 mirror, what we can do good is indentation gonioscopy. That will tell us the state of angle in angle closure, and also how much is the cynical and how much is non-cynical. Will PI work or not work on it? So advantages are many, but disadvantages is difficult to learn to start with and easy to put more force. Therefore, we can get a false open angle. So interpretation, I've simplified to the core. If you see no structure, grade 0. If you see one structure, grade 1, 2 structures, grade 2, 3 structures, grade 3. And the structures we do end-to-end from Schwalb's line to trabecular meshwork to skull spur or ciliary body band. Now starting, people feel making a corneal wedge is difficult. So let's stop the corneal wedge. Let's start from the pupillary border. Let's go the reverse way. So we look at the pupillary border for all the signs, blood vessels, etc., etc. And then we go slightly more careful and look at the contour of the iris. This is very important because normal people will have slightly concave iris, but people who are myopes or who are pigmentary glaucoma, they will have concave. But the real fear lies is what? It is when the iris is more concave. These are the people who are likely to go into angle closure glaucomas. So peripheral iris. Now, where is it inserting? The peripheral iris is inserting actually at the, normally it's inserting at the ciliary body band or skull spur, but it could be even anterior. And if it's more anterior, it's usually these glaucomas are the congenital glaucomas or JOAGs. Coming to ciliary body band, if you see ciliary body band in any gonioscopy, be sure this angle is not likely to close. You are good. Then if we say scleral spur, also we are very sure that this angle will not close. Now anything behind that would be a ciliary body band, cyclodialysis cleft or iododialysis, this thing. The uveoscleral flow is behind the scleral spur and TM flow is ahead of it. So it's a very important landmark. And this white line is very, very important for all of us to keep in mind that this is essential to identify. Then comes this beautiful trabecular meshwork, could be pigmented or non-pigmented. Actually, there's a lot of debate on being pigmented, non-pigmented, but the bottom line here stays is that 0 to 1 is fine, 0 to 1, even up to 2 is fine, but 3 is there, then think of diabetes, think of pseudoexfoliation. If it's grade 4, there is no other diagnosis but pigment dispersion syndrome or pigmentary glaucoma. Iris processes. Now these we can see very fine strands going into the trabecular meshwork. They don't cross the trabecular meshwork, and these are very often in congenital glaucomas and also in juvenile glaucomas. So now the angle depth is most deep in the inferior and least deep in superior. And in normal people, the difference is not more than 1 angle structure. Coming to interpretation of angles, if ciliary body band is seen, angle is open. If only anterior TM is seen, then we are in doubt. We must see posterior TM at least 180 degrees. Only then we will call it the angle is occludable or not. Again, I will reiterate, 180 degree posterior TM is not seen. That means we are dealing with something which is occludable angle. Plateau iris, very important thing. You must see a double hump sign over here. If you see this double hump, it is plateau iris. Now, why is it important for us to see that? Because if you look at it here, the actual angle is only this much, but visible is this much. So therefore, when you do a gonioscopy, you will find this angle will easily dilate when you do a dilatation. These are the people who will end up into acute angle closures also. So this is an angle before PI and after PI. And after PI, when we do the gonioscopy, we really get to see that how much is synechial and how much is appositional, and will we need drugs or will we need surgery for this patient. Then coming to iris cysts, these bumps look like lumps in the anterior chamber angle. They don't really bother you unless until there are too many of them. So this pigment is the hallmark of Krukenberg spindle. And then if you look at this angle, it is so black that you can barely differentiate. And this is the so classical Sapolsky line. If you see this ring, this is pseudoexfoliation. And if you look at the iris here, this is defects. And here you will see certain amount of extra pigmentation and pseudoexfoliation material is sitting here in the angle. In NVG, pupils dilate sometimes so much that you can see actually ciliary processes over here. These are the anterior synechias of ICE or axial field Riegers. If unilateral, then it's usually ICE, otherwise it's axial field. This is late onset juvenile glaucoma. Look at these beautiful ciliary processes and the not so well formed angle. This is angle recession. This is the broadening of ciliary body band. This is cyclodialysis and this is iododialysis. This is a heptic which is sitting here in the angle. And this is a trabeculectomy which has been closed by the, what do we call it, iris. This is a case of neurofibromatosis. You will see the angle is not properly formed. And this is a Sturge-Weber syndrome in which if you see here, there are so many vessels and angle is again not properly formed. So how often do we do it? At first diagnosis in all suspects in all the patients, pre-PI and post-PI, every 6 months in a stable angle closure, and whenever the fluctuation is there or the control is poor. Every 2 years in patients of POAG. Now let's come down to checkpoints. It is part of the normal examination and it is not something very specific. So first thing is that we have to get the fear out of it. We have to start thinking that we can actually do it and we can interpret well. Try us with two mirror first, then 4 mirrors. Must indent if there is an angle closure. If there is an angle closure, it's a must see whether it is synechial or appositional. If synechial, how much? And will this patient at any stage require PI or further surgery? Other than that, we look for so many other things like neovascularization. We can look at the haptic in the angle. We can see closed trabeculectomy. We can see signs of trauma. So there's so many things to be seen. So we should be seeing all these things is what I would want to say. With that, thank you so much. I think I wasted time, so I finished in time. Chandrima, any questions I can take from you now? Sorry.
Thank you, Dr. Madhu. That was an excellent talk and an excellent presentation. We will take the questions later because we won't know how we are for time. So
I need to log off because I have another session in another hall.
Okay, then.
Thanks. Thank you so much. Bye. Nice meeting you.